Hello, everyone. It's Dr. Lisa L. Campbell, and I am back with you again for another CCS exam prep. And to ensure that we can get a lot done tonight, we are going to jump right into our first scenario to continue what we started on Monday night. After some careful consideration, I decided that I'm going to continue to guide you through the scenarios, at least until we get halfway through, because I want to make sure that I am continuing to recite the guidelines to you, because I want you for yourself to see how important they are. So let's get to our first scenario. So we have an elderly woman visiting her physician complaining of heart palpitations. A routine office evaluation revealed significant anemia, which reminds me I do have a file for you that I'll upload into Blackboard that talks about normal laboratory values. So she had not been eating well because she recently moved from her home of 30 years. After admission to the hospital, a cardiology consultation suggested that the palpitations were probably due to the anemia. During the gastrointestinal workup, mild gastritis was revealed. After a transfusion of 2 units of packed red blood cells in the peripheral vein, percutaneous approach, her hemoglobin returned to normal range. Patient was discharged to the nursing home with a prescription of Prilosec to control her gastritis, discharge diagnoses, nutritional anemia, and gastritis. Couple of things I want to call out in this scenario. Right now, we are focusing on ICD-10-CM coding. The minute we get to our chapter 22 scenarios, we will immediately transition over to ICD-10 PCS. So I want you to keep that in mind, as you will see scenarios that look similar to this, but when we get to that point, we will code ICD-10-CM and ICD-10 PCS. So the palpitations were the reason for the admission. The underlying cause was determined to be anemia. So let me just pause for a second. On the claim form, the UB04 claim form that is used to bill for inpatient services, there is a field that we use to enter the admitting diagnoses. But what I want you to remember, the admitting diagnoses and the principal diagnoses may not be the same. So, although the palpitations were the reason for the admission, the underlying cause was determined to be anemia, so anemia would be sequence principal. In addition, we should also assign a code for the palpitations, which are not inherent in anemia. What do I mean by that? So, one of the questions that I asked you all 2 weeks ago was if you had taken pharmacology, pathophysiology, the four things that are listed on the AHIMA website, and many of you said no. And so, one of the things that I will be doing at some point in one of these sessions is presenting a mini pathophysiology review. And honestly, I may see if I can get a friend who was a nurse to do it, because she would do a much better job than me. I'll put together the content, but I'm gonna see if I can get her to. She's amazing. See if I can get her to come in and give you some type of mini review. The reason why this is important is because remember, coding guidelines state signs and symptoms that are integral to a disease process are not coded separately. But if they are not inherent, integral, you can code them separately. So I have been just having some conversations with myself. I'm not answering myself back, but I have been really thinking about how I want to get this information presented to you in a manner that you will understand it. All right, so the palpitations is assigned as another code. And so now I want you to take some time and code these scenarios. And when you are finished, I'm going to do something a little different tonight. When you're finished, I want you to type in the chat finished because then that lets me know that I can move to the next scenario. I have a goal of us doing 18 scenarios tonight. So let's get going. All right. So all of you are finished, and this is one of those things that I had in the middle of the night thinking about that I should ask you when you're finished so we can move a little faster. All right. So the codes for this scenario, we have the anemia sequenced as the principal diagnoses, D53.9. We have the gastritis, K2970. And then we have our palpitations, R00.2. Want to pause to see if there are any questions in the chat. And in fact, in the chat, if you can type for me, ready to move forward, that way I'll know that you don't have any questions and we don't have to go backwards. All right, let's get it. Love it. You guys came to fight today. All right, so our next patient, the woman with the diagnosis of cell-mediated immune deficiency with thrombocytopenia and eczema, was admitted for incision and drainage of a foot abscess. Her course in the hospital was essentially unremarkable. The foot gradually improved with intermittent hyperbaric oxygen therapy and daily whirlpool therapy. Staphylococcus aureus grew from the abscess. Discharge diagnoses: abscess of the right foot, cell immune deficiency with thrombocytopenia and eczema. So, the patient was admitted for the treatment of the foot abscess. That was the focal point of the encounter. So that is the principal diagnoses. And so when we get to the point where I'm going to do your domain review and the specific task, I'll talk a little bit about and show examples of situations where the admitting diagnosis and the principal were the same. And so the admitting diagnosis, let me just throw this out there because it popped into my mind and I can't let it go. When we're talking about calculating the MSDRG, which is something that you have to do on the CCS exam, the admitting diagnoses is not factored into the equation. Just wanted to call that out as we go through this journey. Everything I have in my big old head, I want to give it to you. All right, let's get started with this scenario. All right, so it looks like everybody is finished. So I'm going to display our codes. And so, as I've already mentioned, the foot abscess is the principal. So L02611, the code for the cell mediated whatever, and then a code for that staphylococcus. So, any questions on this scenario before we move to the next one? All right. So, our next patient had locally advanced bladder cancer. He had excellent response to chemotherapy administered prior to admission, with only a small amount of residual disease noted in the bladder. So let me pause here and call out a coding guideline. It was from the other day, but it wasn't in one of our scenarios. But there's this guideline that says, again, I'm paraphrasing because I don't have the guidelines in front of me. But basically, you can't code something as a history of a neoplasm if there's evidence that the patient still has the condition or they're still being treated for the condition. So, in this particular case, prior to being admitted, the patient had some chemotherapy. So, we know that the patient still has the cancer. I also want to call out it would be inappropriate to assign one of those Z51 codes, admission for chemo. We talked about that the other day because that happened before they were admitted. I happened to, so I don't know if I mentioned this to you guys, but during the day, I work as a healthcare consultant and I do a variety of things. But a few hours a week, I work with some physician assistants. And earlier today, I saw like this huge stack of patients that they had diagnosed the Z5111, I think is the number. And so, since they're coding their professional services, if they're going to list that, then I should see a CPT code for the chemo. 100% of the time, that code wasn't present. So I told you that story just to tell you that providers definitely need us. And even with the implementation of AI in coding, we have to ensure that we know what role we are going to play. So someone also said to me, "Hey, why do you read those scenarios?" Well, I do it because if you ever have an opportunity to educate a provider face to face, pre recorded, live in Zoom or Teams, you got to know how to pronounce these words if you're asking a question. And so I do that as a way for people to coders to hear the words because oftentimes you just see them, but you don't really know how they're pronounced. And just so you are clear, I can't pronounce every single word in the medical language. Back to the scenario. He was admitted with increasing nausea, anorexia, fevers, and constipation. His calcium levels were found to be elevated. A slight decrease was achieved with IV hydration. Calcium levels returned to continue to fall with IV Pamidronate, that sounds good. Because he was asymptomatic, further workup was not indicated. He was discharged. Discharge diagnoses, hypercalcemia, and then the bladder cancer. And I just want to call out coding guideline. Signs and symptoms that are integral to a disease process, not coded. So the nausea, anorexia, fevers, and constipation are actually inherent to hypercalcemia. Now, you may be saying to yourself, I know you're going to do this review for us, but what could I use in the meantime to help me learn which signs and symptoms are integral to a disease process? And I'm glad you asked that question. And the answer would be the Merck Manual for Professionals. You could actually go to the Merck Manual, not the Merck Manual for home use, but the Merck Manual for Professionals. It has the diseases in there. You can find the online version. You can plug in the disease, and it'll tell you everything you didn't want to know about that disease, but everything you need to know, such as signs and symptoms, how conditions are diagnosed and treated, and all the things. Coincidentally, that resource, Merck, happens to be a resource inside of 3M. Back to the scenario, I am going to set the timer so that you can begin your coding process. All right. I see that everyone is finished. And so here are the codes for this scenario. So we have the code for um, now I can't remember the hypercalcemia. I couldn't remember at first. And then we have the code for the bladder cancer. All right, guys, we made it to chapter. Oh, let me go back. Question, any concerns with these two codes? I got too excited. Hmm. All right, so now we are moving on to chapter 4, guidelines. So remember, in case you're wondering, um, you know, when are we going to get to PCS? Um, we are at C4. We got to get to C22 and then again immediately over to PCS. All right, so our first scenario, the patient is admitted for chemotherapy due to a primary hepatocellular. Wait, that scenario looks like it's wrong. Yeah, like I feel like we did that scenario previously. Okay, what we're gonna do is take a 10-minute break. Um, and I'll have the correct scenario up because this is not the scenario. I think we did this the other day. I'm sure we did. So let's take a break real quick. All right, everyone, we're going to go ahead and get back going. So I apologize for that. So here is the correct scenario. So the patient is a type 2 diabetic admitted for treatment of a grade 3 foot ulcer, which involves necrosis of the muscle on the left midfoot with gangrenous changes resulting from diabetic peripheral angiopathy. The patient also has diabetic proliferative retinopathy with macular edema and diabetic neuropathy. So there is something that I want to mention, so this doesn't have to be a topic of discussion later. Um, this patient is a type 2 diabetic, and as I know, many of you know, there is a long term use of insulin code. And in one of the resources that is available in 3M, it is noted that you can actually use Z79.4 to show that the patient is on insulin long term. I'm sorry, you know what? I'm thinking about something else. We need to use that. I was thinking about type 1 diabetics. Put a pin in that thought. I'll come back to what I was going to say. You know what? Let me just say it now. If you have a type 1 diabetic, you can use the Z79.4 long term use of insulin code as an additional code. That's what I was trying to say. But this patient is type 2, they're on insulin. So you definitely want to use the Z79.4. All right, I guess that scenario being messed up just threw me off. But nonetheless, let's get to coding. All right, so let's unveil the codes. But before we do, there's a guideline. There is a guideline that we should really think about. Actually, there's two. There's actually two. Um, this is related to the first one I'm thinking of is related to diabetes coding. And the guidelines say something like diabetes codes are combination codes that reflect blah, blah, blah. Um, but also use as many diabetes codes to identify all the manifestations that the patient has. Um, and I think it talks about, but if not, the tabular list does. There are some instances where you need an additional code outside of the diabetes, endocrine code family to fully classify that condition. And so one example is the foot ulcer. You need another code to identify that ulcer, and it's not a diabetes code. Um, One other guideline. Now, I haven't asked you to read section 2 and 3 of the guidelines yet, right? Because you are still focused on reading the chapter specific. But I would be remiss if I didn't call those guidelines out because they impact these scenarios. And so, section 2, selection of principal diagnoses, says when two or more diagnoses equally meet the definition of principal, either could be sequenced first. So, all these diabetes codes that we have, two of them in particular could in fact be sequenced first. So, let me roll out the codes. So E1152 or E11621 could be sequenced as the principal. You'll notice that there is the L97.423 for that ulcer. And then we have additional codes for the diabetic proliferative retinopathy with the macular edema and the diabetic neuropathy. And then in my rambling earlier, I told you about Z79.4. And so you already know that that is a code that was needed. So let me just pause to see if there's any further clarification needed on this scenario. And even though you're reading these guidelines, this time as we're going through these scenarios, I encourage you to keep reading them so that you can get to the point that we've discussed a lot, right? That you have knowledge that they exist, you understand them, and you can apply them. All right, everybody is ready, so we'll continue on. So the patient was admitted for an evaluation of her adrenal malfunction. She had a 4-year history of hypertension and hypokalemia with evidence of primary aldosteronism. A non-contrast CT scan of the abdomen also suggested a left adrenal mass. She was discharged and was to return for a left adrenalectomy the following week. Discharge diagnoses: probable adrenal mass left, hypertension, and hypokalemia, probably due to the primary aldosteronism. That's one of those words that I definitely cannot pronounce. Okay, so couple of things here. You have this adrenal mass, you have the aldosteronism. Either of those could be designated as the principal because the patient, if you go back to the beginning, the patient was admitted for her adrenal malfunction, right? So either of those could be principal. Also, another coding guideline. um, okay, actually two. So in the principal diagnosis guidelines, there is a statement that says if the patient has two or more interrelated diagnoses, either could be sequenced first. So interrelated is like in the same system. You have an adrenal mass, but you also have the aldosteronism. Aldosteronism. Either of those could be principal. So that's one guideline. Another guideline is when you're coding inpatient, please keep in mind that we do code probable, suspected, I think it is, it could be, it might be, as though it exists, unless a chapter specific guideline trumps that. So I will hit the timer. And if you have questions, don't forget to use the chat feature. Thank you. All right. I was just looking at the calendar and I'm like, whoa, we've already been together for 3 weeks. Time goes by fast and time waits for no man or woman. All right. So for this particular patient, we need to capture the codes for the adrenal mass, the aldosteronism, the hypokalemia, as well as the hypertension. Any questions on these codes before we move to the next scenario? And if you have questions, don't forget, type them in the chat. All right, we'll keep rocking and rolling. Our last question for chapter 4. So, the patient with type 1 diabetes mellitus, seriously out of control, was admitted for regulation of insulin dosage. He had a recently abscessed right molar, which was determined in part to be responsible for the elevation of his blood sugar. The patient had been in the hospital 3 weeks earlier for an acute transmural myocardial infarction of the infero posterior wall. And an EKG was performed to check his current status. Discharge diagnoses, myocardial infarction, abscessed tooth, and then uncontrolled type 1 diabetes. As a reminder, um, ICD-10 does have codes to specify hyperglycemia and hypoglycemia. All right, so I don't have to go over anything else for this scenario, with the exception of, per guidelines, as it relates to myocardial infarctions, there is this 4-week rule. This patient is at 3 weeks. Now I'm done talking. All right. As I was waiting for us to get going, I realized I had a typo on my slide, which I'm going to try to correct, but I can't see the screen. Up there it is. All right. So here are the codes. And make sure that screen is big. All right. So, any questions on these four codes? So we have the type 1 diabetes. It is not controlled. So that is with the hyperglycemia. Then you have the code for the abscess. You have the code for the, um, one second, because my mouse is acting crazy. Then you have the code for the myocardial infarction. And I was actually looking this up. So ours was inferolateral, and so that should be I-12, I-2119. And then, as I mentioned, type 1 diabetics always require insulin, and this code can be added just to provide some additional information. All right. Any questions on this? And you guys were lucky that my microphone is on mute because I dropped my ICD-10-CM manual on my foot. And you know how big those manuals are. They are just can put a hurting on you. All right. So since we just finished a chapter, let's go ahead and do let's go ahead and do a 10-minute break. Um, just so I want you guys to be able to get up and stretch your legs, use the bathroom, all that good stuff. All right. So we are now embarking on chapter 6. We are killing it tonight. Let's keep going. All right. So our next patient, whoa, it's long. 50-year-old female with terminal metastatic breast cancer was admitted to the hospital because of severe neck pain. And did we do number 5? I thought we did. Or did I skip 5? Oh Lord, I skipped 5. I got too excited. All right, let me just reel it back. I was too excited. I was like, "Well, we did 3, 4, and 5." All right, here we go at 5. Thanks for keeping me honest. All right. So the patient, a 22-year-old male, was brought to the emergency room and admitted because of acute alcohol inebriation. Blood alcohol levels were documented by an ER physician as 28 milligrams over 100 ml. The physician documented a diagnosis of acute alcohol abuse with intoxication. The physician documented a diagnosis of acute alcohol, the attending physician, acute alcohol dependence with intoxication. On day 3 of the admission, the patient began experiencing delirium tremors, which were managed medically. Additionally, the physician documented that the patient had a nicotine dependence, smoking 2 packs of cigarettes a day. So now, since you've seen chapter 6, the first scenario. That means we definitely got to get through 6 tonight. I'm hoping 7. All right, let's get this scenario going. You can also use participation as attendance as well. All right, everyone. So looks like most of you are done. So I will get started with this scenario. Okay, wait 1 second, because my mouse. I have two screens, so my mouse is always hiding. So I forgot to mention a guideline, and that guideline. And wait 1 second, because I see now how I got off track earlier because my mouse was in the wrong place. So there's a guideline. It's in chapter 5, of course, that talks about it's called some type of hierarchy, and it's like 3 bullets, and it says something like if the patient uses alcohol or drugs, you code it as it's use, abuse, and dependence, something like that. No, use, abuse, and dependence. Anyway, but if the patient has abuse and dependence, you only code um, dependence. All right. I told you I don't have the guidelines in front of me. I closed my book again. So, um, but you're reading the guidelines, so you probably remember what I was talking about. So here are the codes. We have a code for the um, alcohol dependence, have a code for the blood alcohol level. And if you didn't pick that up, you didn't do that rule I told you about. And that rule was when you're looking at a code in the tabular list, it's a good idea to go to the three-digit code to see if there are any notes that apply to that section, because a lot of times they'll put the note there and then it applies to the whole area. So if you don't go back to that 3-digit number, you may not see it. Now, of course, real world, the more you do it, you'll remember it. And then we need a code for nicotine dependence as well as additional diagnoses. Any questions on this scenario before we go to the next one? All right, so there was a comment about the delirium, and that happened on day 3. Okay. Um, Next, 45-year-old male is currently receiving treatment for alcohol dependence. And as a result of his alcohol dependence, the patient is also being treated with medication for chronic alcoholic gastritis. The patient is also dependent on nicotine, smokes a pack of cigarettes daily, and has a history of cocaine dependence. And because the patient has a history of drug dependence, it is classified as in remission. So cocaine dependence in remission. All right. I think you guys will be able to knock this one out. So let me let you go ahead and get started. All right. So for this particular patient, we had 4 diagnoses. We had the alcohol dependence, the gastroenteritis, the alcoholic gastroenteritis. We had the tobacco, cigarette dependence, and then cocaine dependence in remission. Questions on this one? All right, last one for chapter 5. This woman, the woman was brought in by police for observation of a suspected mental condition. They found her roaming the streets and she seemed disoriented and confused. She was treated for scabies, body lice, and cellulitis of the right foot. Her mental status cleared rapidly. The social worker was asked to assist the patient with her lack of insurance. The documentation from the social worker indicated that the patient was homeless, currently residing in a shelter. I hope I got all the social determinants of health on here. The only psychiatric disorder found was moderate intellectual disability. Discharge diagnoses: moderate intellectual disability, scabies, body lice, cellulitis, right foot. So I just kind of blurted that out, but I hope I got those codes on there. I believe I do, but we need to definitely assign those codes for the social determinants of health. And don't ask me what day it was, but it was the day that we kind of went over the section 1A and 1B guidelines. And we talked about the fact that social determinants of health can be captured from a non physician. And in this particular case, it was a social worker. Yeah. So those are secondary diagnoses. But um, we want to get that principal diagnosis, right? So the scenario starts off by talking about the patient was admitted for observation for a suspected mental condition. Um, but it was identified that the patient had moderate intellectual disabilities, and that, was the reason for the disorientation and the confusion. So just want to call out that you would not use a code for observation. Um all of those non-psychiatric conditions do meet the definition of additional diagnoses, i.e., Section 3 of your ICD-10-CM guidelines. They were diagnosed and treated, and so um, they should be assigned as secondary codes. Now, I know some of you are saying you hear these guidelines ringing in your head, but I have to keep saying them over and over and over again. There's another code that I hope you guys pick up on. I'm not going to say anything about it just yet, other than that it's another Z code. So let's just see where you land, because as a reminder, all of you hold some type of coding credential and and many of you are working as coders. So I don't want to give away too many of these guidelines. All right, let's go. All right, so here are the codes. So you have your code for the intellectual disability. Also capture the code Z9183 for wandering. And this code can be used when wandering um, is related to a disease or condition that's documented by the provider. So it is clinically relevant because the doctor said the patient um, was wandering and they had intellectual disabilities. And I believe in the tabular list, it says that the intellectual disabilities should be coded first. We also have all the other stuff the patient had, the cellulitis, the lice. Now I can't remember the other condition names. So the scabies, the body lice, the cellulitis. Then we also picked up those codes for the social determinants of health. And someone asked me if external cause codes were on the CCS exam, if Z codes were on the CCS exam. And what I want to say to those type of questions is you should, yes, you look at the content outline to see the floor of what you are expected to know, but the floor is not enough. So instead of being focused on little things like that, just know how to code, right? And then no matter what they throw at you on that screen, you can attack it and it won't attack you. Now, right now, you're coding scenarios, they're not multiple choice. And the goal is like I just want you to know how to code, right? Without a computer, just you versus the computer, and you winning. Like you sit at that computer and you're like, I'm in charge. Fall back because I'm gonna pass this CCS exam, right? That's what I want for you. I don't want you to be like having your head, well, I just gotta focus on this because this is all they want me to know. All right. So any questions on this one? And I'm smiling on the inside and outside because chapter 6 is next. If you could see, I have a little notebook. Well, you can't see because I don't have my camera on. But, and I told you I don't have my camera on because this system kind of drains my resources. And so it makes the class, the platform drag. But anyway, I have a little book and I have C1 through C22 written down. And as we go from one to the next, I cross them out. And so now I am ready to cross out C6. So let's get back to a scenario that I was trying to get to accidentally. Um, and I see some no's popping up in the chat that you don't have any questions. So I'm going to keep on rolling. Whew, all right. 50-year-old female with terminal metastatic breast cancer was admitted to the hospital because of severe neck pain. Pain got worse over the past week in spite of increasing amounts of oral pain medication. Patient was admitted for pain management and initially given PO morphine 10 to 15 milligrams Q every 4 hours, 4 to 6 hours for pain. So something I want to call out here, and you'll notice I'm being very intentional by bringing up things now that we're going to see later. So when we talk about inpatient admissions, one of the things that the doctor has to support is that a patient meets criteria for inpatient stay. And that criteria is tied to two terms that I'll call out and then I'll move on, is severity of illness and intensity of service. And so basically, patients that are admitted to the hospital, they need care, treatment that you can't do at home. So during the next morning, she continued to complain of severe pain and was given IV morphine, 2 milligrams, which relieves her pain. Eventually, the pain subsided. The morphine was gradually tapered off. She was discharged and referred to pain clinic for further outpatient care. Discharge diagnosis, severe neck pain due to bone metastasis from malignant neoplasm of the right breast. So I hope that you see something. We are in, and let me just go back. We're in chapter 6, diseases of the nervous system. And so and I'm saying this now so I won't forget to say it at the end, you see we're at chapter 6 and you guys are supposed to be reading the guidelines in advance. And so we won't see each other again for another 5 days. So next Monday. Oh no, Monday is actually a holiday, so we will not see each other. So realistically, by the time I see you again, you should have read through chapter 22 of the guidelines. You should be ahead and not behind. But there is a guideline that is pertinent to this scenario, and I'll just go ahead and call it out right now. Patient was admitted for pain management instead of treatment of the neoplasm. So I think you should know that as you consider your code assignments. And let's get going now. Uh-oh, I keep clicking ahead. All right, too much caffeine today. Okay, here we go. All right. So here are the codes. So first, we are capturing um, the neoplasm related pain code G89.3. Um, Typically, the neoplasm code would provide information regarding the specific site of the pain, but it doesn't really, tell you about where the pain is. So you got G89.3, neoplasm related chronic pain, or whatever it's called. You got your cancer code, your primary and secondary, and then you need the code for the neck pain. So that's the M54.2. Questions on this one? Two more and we'll be done for the night. Woohoo! Cooking with gas. All right. Next patient. The patient previously suffered an anterior dislocation of the left hip, which was reduced. However, this was followed by numbness and weakness in the left femoral nerve distribution. Evaluation indicated that she would benefit from surgery. So they did a left femoral nerve external neurolysis, was carried out successfully. Discharge diagnoses, mononeuritis, femoral nerve. And let me just reiterate. Once we get to chapter 22 of the ICD-10-CM tabular list, we will immediately switch to ICD-10 PCS. So I will let you know in advance when you need to start reading those guidelines. But after we have a session of me introducing or reintroducing, however you want to say it, ICD-10 PCS, we will immediately go back to coding scenarios, um, PCS only, and then we'll switch to PCS and diagnoses together. We are skill building. All right, let's let you code this one. All right, I see that most of you have finished coding, so there was something that I wanted to call out regarding this scenario. Um, Dislocation is not coded. It's a previous condition, no longer being treated. As such, the mononeuritis is a late effect of the dislocation. So there is a way to say that this is a late effect of something. And in this particular case, it would be with the seventh character of S. So your mononeuritis would be coded first, followed by that code S73032S for the late effect. Questions on this one? All right, we're going to go to our last scenario. Another patient with type 1 diabetes developed weakness of the right arm and leg. The weakness worsened. Eventually, he fell and was unable to move. When brought to the emergency department, he was able to speak but unable to use his right arm or leg. Consultation after admission suggested either an acute left-sided cortical stroke or a TIA. Radiographic procedures were scheduled. However, he completely recovered before the procedure could be completed and was able to ambulate with no neurological deficits within 24 hours of admission. He was discharged and will have a workup performed for cerebral vascular insufficiency as an outpatient, and the discharge diagnoses, probable TIA, and diabetes. So a couple of things. The cerebral vascular accident was ruled out, so we don't code it. Arm and leg paralysis were transient neurological deficits that completely cleared during a hospitalization, so we don't code those. And as we mentioned maybe last week, in an inpatient setting, you can code probable. I think it is. It could be. It might be. Those are also known as uncertain diagnoses. You can code them so as long as you don't have a chapter specific guideline that um, trumps the uncertain diagnosis guidelines. Also, we should be assigning a code for the diabetes because even though no treatment was given for it, it is a condition that always requires clinical evaluation when any other medical problem is present. And what else did I want to say to you? When I say clinical evaluation, I want you to refer to your section 3 of your ICD-10-CM guidelines. It gives you a list of reasons to assign secondary diagnoses. All right. And as we discussed before, this is a type 1 diabetic, and we can assign the Z79.4 as an additional code to provide additional information, even though it is not required because type 1 diabetics always require insulin. And here are the codes. Questions on this one? Oh, wait a minute. You were supposed to code it. Well, here are the codes. Clearly, I only had 1 cup of caffeine today. So, but it's late. All right. Well, Those are that is hilarious to me. All right, so maybe because it's a snow day today. So as usual, we will end our session by each person doing their recap of the night, and your recap should not be the same as everybody else, so you should think about